welcome to our Pelvic Health Network monthly meeting and discussion. This should be a very inviting discussion for all of you to feel that you can engage in. So please use our live chat, use all of the opportunities that you have to network with each other now before we really get into the meat and potatoes of the question that I've posed tonight of when should OT and PT be offered in the hospital after birth. So when should OT and PT be offered in the hospital after birth? And I'd love to know, just from those who are joining live, I've asked you all to take some time to introduce yourselves, introduce where you're from, your background professionally, your level of involvement with this patient population, those after birth, whether it's in the hospital or whether it's in the home or a birthing center. How soon are you offering rehab services? If you are a rehab therapist, if you're a physiotherapist from abroad, welcome. We're so happy that you're here. Thank you so much for joining us with the time difference. We're very happy to have your presence. And so please share your background and your level of involvement with the perinatal population, whether it's during pregnancy or immediately after birth. How soon are you involved in the care of this population? And I do encourage you, I will be looking at the live chat and seeing your responses come in, and would definitely like to know what your experience is. It's very important for us to get engagement with you this evening, because a lot of what we do is guided by current practice and current events. And so without further ado, I'm going to actually introduce the topic that we'll be discussing tonight in the lens of what we've done or what we've seen clinically, and then we'll open it up to a broader discussion with a special guest that will give their experience about offering OT or PT services with this patient population. Thank you and welcome all. Our main topic tonight, our main question that we're asking all of you is, when should OT and PT, occupational therapy, physiotherapy, physical therapy, rehab, be offered in the hospital after birth? What evidence are we using when determining the answer to this question? Think about that for a second. And then, based on your experience, either personally or professionally, put your answer in the live chat and engage with us about this topic. We want to recognize that a lot of the evidence that we really value, prioritize, whether that's published in the literature, whether that's a systematic review, double-blind placebo trial, whether it's meta-analysis, whatever it is that we're really prioritizing in terms of evidence-based practice guiding us, we want to just recognize the stories and the people that have shaped our practice. When I say our, a lot of the information that we're getting are from current providers who are offering their services very early, at least here in the United States where this is being recorded. For those of you who don't know me, my name is Rebecca Seagraves. I'm a physical therapist, women's health trained, specialized, who offered services primarily in the outpatient environment and then moved into the hospital setting around 2020, so right around 5 years ago. And I started treating families, women specifically, in the hospital during high-risk pregnancy and immediately after birth. And so I've treated a variety of conditions within the postpartum period around the time of their hospital stay that range from vaginal delivery, a cesarean delivery, and cesarean hysterectomy, and other surgeries around that time period as well that might have been going on, or at least expected procedures that included moms who were diagnosed with cancer and who were going to our hospital nearby. That was in Houston, Texas at the time, so ND Anderson Cancer Center, a very well-known hospital here in the United States. And they were being transported from the maternity unit right over to oncology. And so those were very unique cases. The youngest patient I've treated in the hospital was a 13-year-old young woman after cesarean section or cesarean delivery. And so I've had a lot of experiences with a lot of different patient populations that include sensitive patient populations. And so what we'll be discussing tonight is just the recognition of current events, current stories that really drive the practice that's needed from rehab therapists to be involved on the maternity unit, why we are so passionate about providing OT and PT services to this patient population so acutely. And so we'll take time to recognize those factors that come into play. We'll also move to risk factors that we should all be aware of that really backs up our timing of when should OT and PT services be offered in the hospital after birth. And then we'll discuss the parameters of a rehab referral and actually speak to our special guest about their experience of receiving a rehab referral at an ideal timing and then at not so much of an ideal timing. And we'll really compare those stories because I think that's important for you to know why our stance and what we feel the evidence really points to in terms of the timing of our services, why we feel it should be a lot earlier than the current standard of care, which may be 6 weeks for some of you who practice in the outpatient setting. So first, we want to recognize some stories, and we really respect all of you in terms of the need to care for yourself. These are very sensitive topics and sensitive stories, but it's important that we start with that because we really wouldn't be here without these stories in terms of advocating for our services to really support this population. And so our first person that we'd like to recognize is Shantice Hollins. She was a 22-year-old mother of 3. She gave birth January 2nd, and she was found, unfortunately, deceased in her apartment after a wellness check on January 6th. And the estimated time of her death was 2 days prior to January 6th, so around January 4th, she passed away. And this was a woman who gave birth in a hospital system in Oklahoma in January of 2024. And the standard care of delivery care, at least maternity care in the United States, is discharge to home, whether it's a vaginal delivery that may be within 1 or 2 days after birth, or if it's cesarean delivery, it could be 2 days or 3 to 4 days after birth. And so we don't know the circumstances around her death, but we do know that her passing was due to medical complications after birth. And we just want to recognize that her story is one of the reasons why there's a critical period that happens postpartum. And the World Health Organization advocates that there should be at least 4 health contacts during the first 6 weeks postpartum. And so I ask you who are joining us live or who are seeing this recording later is what is the typical number of health contacts that are given or provided to this population after they give birth? In your experience, whether you're joining us abroad or you practice here in the United States and you're aware of the statistics, how many health contacts, whatever that is, maybe it's a touch point with a midwife, maybe it's a touch point with an OBGYN, maybe it's a touch point with a physiotherapist or a rehab therapist that sees this person routinely within the first 6 weeks. How many health contacts are mothers typically given? And for mother's care, not the newborn care. So we're not considering the pediatrician visits, we're considering the care for the mother. The second person we'd like to recognize that this talk or topic is really dedicated to is Drea Austin. She was a 30-year-old mother of 2. She died July 23rd of 2024. And she died 2 weeks after her birth. And she had a known blood clot that was being treated, but stopped being treated right before she delivered. And apparently she either didn't resume the medication that she needed or get the help that she needed in time for the blood clot in her leg to be removed before it traveled to her lungs and caused a pulmonary embolism. And it later stopped activity to her brain. And so she was pronounced brain dead within 2 days, actually of the day that she went to the hospital, where she was transported, July 21st. And then they removed life support. And so her death mirrored a very known person, at least here in the United States, Serena Williams, who's a known tennis athlete who nearly succumbed to a pulmonary embolism. It was found, but she had to advocate for herself, even though she had all the resources that you would think that one would have after her cesarean delivery. She still had to advocate for herself and could have succumbed to a pulmonary embolism, as Drea Austin did. And so we want to recognize Drea Austin. This is not a story that happened in the 1980s or early 2000s. This happened within the past 7 to 8 months. And so we really want to recognize the stories and the current events of why we as rehab therapists are advocating that we be one of the health contacts that the World Health Organization is recommending that moms have much sooner than the standard of care, which is the 6-week postpartum visit with an OBGYN. And lastly, we'd like to recognize Morgan Hughes. Morgan was a new mom of twins, 23 years old. She died 9 days after she gave birth on December 28th, 2024, of peripartum cardiomyopathy. And it was unusual because peripartum cardiomyopathy, as some of you may know, is a condition that affects the heart function, but is usually found more along the later postpartum recovery period. So closer, not necessarily within the first 6 weeks. It was very unusual, but you can imagine just with the demands of maybe carrying or giving birth to twins. These twins, as we know from her story, were admitted to the NICU. And so it's something that we often consider is that for moms who have babies in the NICU, their bonding time is different than moms who are able to immediately bond with their babies. And so their sympathetic and parasympathetic systems are different. And how different, we don't know. For Morgan's case, we don't know if she was walking back and forth to the NICU several times a day, if she was transported by wheelchair when she was discharged. Did she return to the NICU? We just don't know the circumstances really that would have caused her to have such a rare condition that usually affects mothers later on whose hearts don't recover properly. And so we want to remember Morgan's story and just add it to the current events and evidence that we have that's best available to us right now, because not a lot is in academic literature. Not a lot is covered in meta-analysis or systematic reviews that really direct when should rehab services be offered to this population after birth. But we know from the current events, this happening so soon, just less than 2 months ago, we know from these current events, we're pointed to different indicators, if you will, indicators that the Center for Disease Control here in the United States gives us to say this is a person we may want to have on our radar, and this is a person who would benefit from 4 health contacts before the 6-week visit. And so the risk factors that we often take into account as rehab therapists that support our advocacy that rehab should be offered within the first 24 hours after birth. That is our position in terms of the organization that is hosting this talk, Pelvic Health Network, and me as the leader of that organization. I am the co-founder of Enhanced Recovery After Delivery, and it's a clinical pathway that provides access to occupational and physical therapy in the hospital and home after birth to enhance maternal health outcomes. And from our work that we are doing in this area, we advocate that services from rehab professionals should be offered within the first 24, at most to 48 hours, if they're recovering in the hospital after birth. We're using data from the CDC, from Commonwealth, a fund, and OECD, that's the Organization for Economic Development. We're looking at this aggregate data, the timing of maternal deaths. And we know that infection, hemorrhage are huge drivers for deaths that occur during the first 6 weeks postpartum. So within the first 42 days, what is a direct threat to maternal health are things that we want to have on our radar. And so for our rehab evaluation to really start into those patients on the maternity unit who may be at most risk, we're looking at individuals who had a history of a high-risk pregnancy diagnosis because they may have been exposed to medications that stop or prevent or designed to slow preterm labor. And we know that those medications have a direct impact on the cardiac muscle. So anyone in our maternity centers who has had a diagnosis of high-risk pregnancy, if they have delivered within our hospitals, there should be a screen in place, either from nursing or either from the medical team or either from rehab therapists that I used to do when I worked at Texas Children's Hospital when I first was working with this population inpatient. We would do our own screens on the maternity unit just by those who had given birth. If they gave birth by C-section or had a high degree perineal tear, we would take note if they were diagnosed with high-risk pregnancy, with preeclampsia, we would make a note to offer our services to that population and then do a deeper dive on the next part that we'll discuss, their home environment, their social factors that may determine if they're at risk of complications further when they return home. We also do a screen, as we said, on surgical delivery. So that's the not only cesarean delivery, but high degree perineal tears often result in a surgical repair of the perineal tissue or the sulcus of the vaginal wall. And so we would do a screen for those patients to see if they would benefit from OT or PT services during their hospital stay. We would also do a screen for those patients who had postpartum hemorrhage that resulted in a hysterectomy, or just postpartum hemorrhage that would result in their inability to walk independently without a walker, without handheld assist from a nurse. That would be an automatic screen as well. Hypertensive disorders and thromboembolism, we would look at those patients collectively and really make the decision that if their activity exceeded their physiology, they should receive a screen as well from an OT or PT who could really assess and address whether they're putting their physiology at risk and going home to do the demands of newborn care and self-care that would put their hypertensive disorder at risk of becoming eclampsia, which is a seizure, from preeclampsia, which really affects the function of the organs and can lead to death as well. And thromboembolism, of course, really should be an automatic because there should not only be medical involvement, but just physical or occupational involvement in determining the risk of that person doing their normal daily activities that could put them at risk as well. And then infection. This was a population, unfortunately, that we waited a lot to see when they were readmitted to the hospital. And so this would be a population that we would want to see if they're at risk of infection, especially if they're maybe an obese person and they have a pannus and they had a C-section. That pannus can cause and breed a firestorm for infection. And so that would be a patient population we would want to screen as well. The sociology factors that we use are really guided by Gunja and her colleagues from the Commonwealth Fund, who really has been tracking for several years now the mortality rate up to the first 42 days postpartum. And this is showing a graph of all of the high-income nations that have maternal death rates in the first 6 weeks. And in red, the United States is divided by race. The other countries are not. And in our countries, in our nation, Black individuals after birth have a significant higher rate of death than other racial groups. And so we typically suggest that rehab is offered to at-risk maternal groups, regardless of the other 5 factors here. Because this graph actually does not account for the differences in economics, for the differences in comorbidity, for the differences in health literacy or education, for the differences in geography. This graph is primarily just depicting a person's risk of dying, at least here in the United States, by their race alone. So we say if there are at-risk maternal groups because of race, we should be screening them for their benefit of receiving OT or PT services because we can't account for any other thing that puts them at such a high rate of death other than the race in their country. We should also be screening those individuals who have limited social support. So if they're single parents or even first-time parents, in Colorado Springs, where I live, we have a lot of veteran families who are separated from their families or other parents or in-laws that could help. So we often will screen for those with limited social support and offer them our services. Those individuals with multiple children, those individuals with mental health challenges, we know that mental health actually outpaces cardiovascular conditions in terms of the leading cause of maternal death up to the first year and during pregnancy. We know that mental health challenges are the leading cause of maternal related deaths. And so we really want to screen and offer our support for those individuals who might be overwhelmed with sequencing and the task around home management and self-care management before they go home. And an OT provider would be well suited because of their background in mental health. And so that would be a provider that we would want to advocate for offering this. And those with health literacy limitations, and of course those with financial challenges who may find it difficult to navigate between the care their child needs and the care that they need as well. And so when we're referring to rehab, I'll talk with our guests in just a moment about outcome measures, but there's two that we suggest that you use to determine when you should offer rehab services within your maternity care center. If you are the one that makes a decision, if you are a director or CEO of these facilities, we really advocate that you're using outcome measures to guide your decisions and not your gut. We know that our gut will tell us that this is a young population. They're healthy. They don't need another allied health professional. But if we use evidence, we would be asking questions specific to that person's knowledge and confidence with managing their surgery. And so this is the readiness for hospital discharge scale, postpartum form. This is the long form. So I'm showing you the latter half of the questions here. And that question that I just asked about in terms of surgery is really talking to that person. These are questions that you would ask a mom before she's discharged from the hospital after birth. Is how well do you feel you're able to manage your surgical care or your incision or your personal care around surrounding whether it's a cesarean incision or whether it's a perineal laceration repair? What are the surgical precautions are they familiar with? How about lifting restrictions? Number 13 on this screenshot, ask how much do you know about restrictions, what you are allowed and not allowed to do after you go home. It could be their lifting precautions. How about their demands of life at home? How prepared do you feel you're able to handle the demands of life at home? How about your personal care, your incision care, like we said before, your ability to care for your baby? Who do you have that can help with household activities? Who do you have that can help with maybe newborn care support or maybe the care of other children? We should be asking our patients those questions in order to determine if they would benefit from more education surrounding their mobility, their activity, and around advocating for themselves. And then we want to assess function. And that's why we advocate for the first 24 hours after birth to use a measure like the activity measure for post-acute care. That's the AMPAC 6 clicks. And this is a widely used measure here in the United States in acute care hospitals, where OTs and PTs, there's one for ADLs and basic mobility for PTs generally, is that we're looking at that person's ability to get out of bed, which we know after a cesarean delivery or a cesarean hysterectomy, a procedure that lasts 4 to 13 hours sometimes in duration, where that person now has to get out of bed, a bed that is similar to theirs at home that doesn't have hospital rails and is flat and it doesn't adjust like a hospital bed. We know that could be incredibly difficult, especially given the demands of newborn care and if the baby is crying. So I really want you to just consider assessing their bed mobility and not just thinking this is a healthy young population. They don't need our services. No, no. Use evidence from an outcome measure that actually assesses their ability to get in and out of bed, their ability to sit to stand. How about the person that I saw 2 days ago who had a symphysis pubis dysfunction injury because the way she delivered on her back required her medical team to really pull her knees back to her chest, right? Her shoulders even. And when the epidural wore off, she could not walk. So our team was consulted a little bit too late, in my opinion. On the second day, she was already being discharged, but she could not get up her stairs to go home. She could hardly walk with a walker, and her gait was so slow. We would say that she would be at a risk, high risk for falling, and she could not walk and carry her baby. And so those are the things that we're asking you to use, are these outcome measures where you're assessing function, their ability to shower. A lot of them are not sent home with a shower seat to make sure that they're safe and that their energy is being conserved and that their heart is being protected, especially the cardiac muscle that may be at risk for cardiomyopathy and other conditions where there's too much exertion when the heart muscle is still recovering from the demands of childbirth. So we ask that you really do consider using all of the evidence that is available to you. And in the absence of evidence in the literature that can guide our answer to this question, when should OT and PT be offered in the hospital after birth? In the absence, we're collecting stories. As Pelvic Health Network, we are visiting moms in different states, and we're collecting their interviews and their stories from their cesarean and vaginal deliveries and other complications that they may have had or other wins and benefits that they actually encountered from being offered an OT or PT during their hospital visit. And we're collecting those stories on Pelvic Health Network on their YouTube channel, which anyone is able to access and just listen to mothers directly who are explaining what their response was to either not receiving rehab during their postpartum stay and what they would have liked to be taught. Some have talked about an abdominal binder. I wish I would have been given an abdominal binder to really protect my incision or to really compress the pain. Some have said of their experience that they were overjoyed that they were offered a physical therapist or a physiotherapist evaluation during their hospital stay because it was so overwhelming and their surgery was unexpected. So we really do encourage you to use the best available evidence that you have now until we have more information that we can publish in the literature. Thank you so much for your time. And I'm delighted to now invite my guest to speak with me about her experience treating this patient population in the hospital. Welcome, Dr. Jenna Seagraves. I'm absolutely delighted to have you join us. Will you give a little bit about your background to those who do not know you?
Absolutely. And thank you so much for having me. My name is Jenna Seagraves. I am a physical therapist. I'm a board certified neurologic clinical specialist and a certified lymphedema therapist. The majority of my clinical background has been in acute care, working at level one trauma centers. And I have a passion for working on the neuro, the trauma floors, the critical care, emergency department. And I started to fall in love with the peripartum population. And something that really got me into working with this population or really trying to strive for change in this area is I was starting to see more and more individuals who were returning to the hospital within hours, maybe up to a couple of days, but the quickest one was within 12 hours after being discharged from their after delivery from their initial hospital stay. And they were being admitted for a multitude of reasons, but some of the most impactful ones for me were those that were being readmitted for pretty urgent hypertensive emergencies that resulted in hemorrhagic strokes. And I'm sure we can all appreciate what that may mean. This is now someone who not only has a newborn, that they are caring for, but they have a pretty significant neurologic recovery ahead of them. And I just started to think to myself, is there has to be something that we could have done. There has to be something that we could have done sooner to even potentially prevent this from happening. So sorry, I went off the rails there, but that's why I really am super passionate about expanding services to this population. Now, I transitioned into full-time academia. So I am a clinical assistant professor for a doctor of physical therapy program. And so I do teach DPT students full-time, but I do still practice clinically as well.
Thank you for actually giving your background because I want to touch on a few different things that you mentioned there. But let's actually
Sure.
just start where you left off. So you're teaching doctor of physical therapy students here in the United States about offering rehab services to the maternal population acutely. Am I understanding you right?
That is brought up, yes. And so I'm involved in a number of different courses, and something that was really important to me is this is not something that's really discussed in school. I don't know if anyone else can relate to that, but that was definitely my own education as well. And that needs to change, in my opinion. And so, even as early as anatomy, so in DPT programs, most of the time students are starting in anatomy to learn just the human body. And even within there, we are starting to talk about the abdomen and the viscera and everything located there. And we are able to, I can weave in, hey, let's talk about abdominal surgeries and what would this look like for this person. And we integrate and talk about what would a cesarean section look like? How many layers are involved in that? Now, I want all of you to think about how difficult would it be for you to get in and out of bed if you had all those layers that were now cut into? And so we start as early as there. And then once we get into, I'm involved in the cardiopulmonary courses, the acute care courses, neuro, and there's so much that we can tie in there. And lots of examples that I like to do is give a lot of clinical examples. And I think that is helpful for students because they can learn the didactic, just textbook information, but now we're going to tie it to this case. And so I like to bring in cases like this where I've actually worked with them and they need to be thinking about, okay, this is an abdominal surgery, but what do we know about abdominal surgeries? We know that it could affect their cardiopulmonary system. We want to make sure that their vitals are stable because we're in the acute care environment. And so we really hone that in on them as vitals are vital. And looking at endurance, and we want to look at gait and just thinking, oh, these are all these things that we should look at with this person too. Why are we not? And what's funny is that I try really hard not to frame it in any way about how this is not something that we currently do. I start off by just making it like, yeah, here's just a case that just like all the other cases and all your other courses that you would ever get, so that to them it's just commonplace. I want them to realize, oh yeah, here's just another thing. We have students that are from all types of backgrounds. We have many, actually, I work in a hybrid program. So we get a pretty large portion of non-traditional students, and we have a large portion right now that have children themselves. And so quite a few will make comments like, wait, how come I didn't get that? Or I didn't know that we could do that. And that's a nice way to get in there about this is actually what I am really interested and really passionate about doing. And you can help change this. I really believe that students are our future. I believe
And
that
just to
pretty
clarify,
firmly.
you're saying that there are students in your DPT program who have had children themselves, maybe by cesarean delivery, who
Yes.
are actually asking and questioning because of the way that you're presenting this is that you're normalizing not just therapy services, rehab after cesarean delivery, but you're normalizing the timing. So it's not just pelvic
Mhm.
health, which a lot of our maternity services under rehab care has been framed under as
Mhm.
outpatient pelvic health. You're framing this as acute care within the first 24 to 48 hours during the hospital stay of acute care therapy services being offered to this population after birth. And you're framing it as being normal, and they're asking the question, why wasn't I
Hmm.
given this if this is normal?
Hmm.
And it's
Hmm.
making them think of all the benefits that it could have provided not only them, but other future moms. Is that right?
That's exactly right. Yes.
I have a question for you, something that I'm going to pull back from what your very first example was, because this is important for our live audience to then talk about as a group. And I really want to open it up to some discussion. But you mentioned specifically that you started to question, why are we not offered as a standard of care? When you started seeing moms readmitted to the hospital within 12 hours, would you be willing, without giving patient information, to just describe one of those situations where you actually received a rehab referral when the timing wasn't ideal, and what made you start to think about the timing of when rehab services should be offered? What made you start to think we need to be involved a lot earlier than we are?
I just want to make sure I understand your question. Are you saying you want me to give an example of a time where I received an order where I felt like it was too late? Is that what you mean?
That's
Or,
absolutely
okay.
right.
Oh, okay. Yes. So that case that I alluded to at the beginning, I think is a great one to expand on. And so this was someone that was admitted to the ICU. And upon chart review, as we would with the standard patient after someone who's had a stroke, we do get automatic orders for someone after a stroke in the hospital. They receive automatic speech, OT, and PT. And so upon doing that chart review, you can see, oh, this person had a cesarean section 4 days ago. And then I start to look into, wait a second, they were discharged and sent home and they returned to the hospital within 12 hours. And so now working with this person, and just to give a little bit, of course, without breaking any form of HIPAA, but this person really was having some neurological deficits. She had pretty significant left-sided hemiplegia. She had to relearn how to speak. She could not swallow. She had to relearn all of that. And one of the most limiting issues was she was having recurrent seizures, and it was during activity. And so it really limited what we, progression with mobility and with therapy. And so anytime we tried to stand, um, another seizure would happen. And it was very scary. I'm going to be completely honest. It was very scary. And that was just this plus other, I have other examples, but this one in particular was really where I thought, is there any way we could have caught the hypertension that led to her hemorrhagic stroke while she was in the hospital before, with that initial after delivery, that initial hospital admission? Could we have caught this? Because therapists, rehab therapists, we simulate activities that they're going to do at home. We work on mobility. We advocate for their independence. And we do all of that while assessing their vitals. And we make sure that they are staying within safe parameters to where we feel comfortable that they'll be able to go home safely. And so those were, did that answer your question?
It did, but the argument of if our nurses are doing that already, do we truly need to add another allied health discipline to the maternal care team if we're trying to get more midwives here in the United States within our
That would be
hospitals and
great.
just being part of the maternal care team, which is awesome. It's about time that we catch up with everyone else. But we know we have a low ratio of utilization of midwives, so we're trying to add more of those allied health professionals. What would we really be adding to maternity care services, in your opinion, for this patient population within their hospitalization after birth?
I think that's a great question, and I have a lot of answers for it, but I'll start with one that I think I already alluded to, is that I say we, and I'm sorry for saying that, but rehab therapists, so occupational and physical therapists, we consistently take vitals during activity and immediately following said activity to see how is the body responding to that activity. And most nurses on the OB floor tend to do it at rest. And it's not to their faults or anything like that, but that's just when they have the time to do it. A lot of times it's to try to help with discharge. And so they want the numbers to be at a certain level. And so let's have them be resting. Let's have them in the bed so that we'll get the best reading. I don't care about the best reading. I care about what is the body going to do realistically during actual activities that they're going to have to do once they go home and they don't have a medical care team who can just grab their baby for them or can go do X, Y, and Z. They're going to have to get out of their bed to go to the bathroom. They're going to have to get out of their bed and go pick up their newborn, care for their newborn, change diapers, do all of it. And I care about that reading, those vital signs. The other piece, because I said I had a lot of answers, but I'll keep it brief. Another one is that a lot of times, I don't know about anyone else, but I've never actually seen a nurse take someone up and down stairs in the stairwell. And I think that can be very crucial because some individuals may have to navigate stairs, whether it's to even enter their home or maybe that's where their only bedroom is located. And that's something else we need to make sure, can they physically do it? And what is their body's response after doing it?
I completely agree. I think that from professional experience working with this population inpatient, I really haven't seen anything in terms of just making sure this person can walk from their car to the front door. There's just no training. It's nil. I've been involved in cases where moms were either readmitted or they were confined to their couch after being half carried in
Oh,
because
wow.
they just then realized, I'm not sure how we're going to get out of the car and walk. And
Wow.
I really took for granted how common it was after birth to just make sure mom could transfer to the recliner and hold her baby and then transfer to the wheelchair. And there wasn't that intentional assessment of their ability to walk and then perform the activities like showering. No one thinks to
Mm-hmm.
provide a shower chair to
Right.
someone in their 20s or 30s after delivery the way that we would be making sure and checking the box in other acute care settings. And so I'm really fortunate to still be involved in acute care practice as a physical therapist because I'm constantly comparing the care that we prioritize for these other populations and we deprioritize for moms. And
Mm-hmm.
so that leads me to really open up the questions to those who are attending with us live. If you are a rehab therapist or a healthcare professional, maybe you are a nurse, a midwife, an OBGYN that's seeing this, and maybe you're starting to consider, there might be a benefit or you still feel like there's a waste of resources, we invite you to come with us. You can unmic or put your camera on, but we invite you to ask questions, to add to this conversation, add your perspective, but then also share what you think are the barriers to offering rehab. Now that we've answered that question, at least with our experience and our clinical judgment, we're answering the question that rehab, OT and PT, should be offered within 24 hours in the hospital after birth. And we want to know what your immediate knee-jerk reaction is. Don't think too hard and don't be too shy. Your opinion matters. Just like the stories we shared at the beginning that were so vulnerable and so hard to really gather from just this past year alone in 2024. We're sharing stories of women who have passed away and left their families behind. And so we want you to feel comfortable with us sharing your real deep, either concerns of offering rehab this early or your why for why you do it and why you believe it should be a standard of care. We want to hear from you. So please take a moment, those of you, and offer to join us for a conversation. What do you think?
Yes, please join us.
And Jenna, as people are either coming on or indicating or maybe interrupting us a little bit later, are there any things that anything at all that you want to leave the audience with to just think about? What should people really be thinking about when answering this question? When should OT and PT be offered in the hospital after birth? What would you want to leave them with?
Me, I agree with what you were saying at the beginning is that the first 24 to 48 hours really would be ideal. That's when I think we can make a big difference, particularly since the vast majority of these individuals are not followed up until 6 weeks. And that's usually when they're being followed up with their OBGYN, but that's also standard of care for pelvic health therapists in general who may be working with this population as well. The majority don't see them until 6 weeks. So, what's going on in those first 6 weeks? On your chart, you said that we lose well over half of the deaths that take place in those 6 weeks. And so, those that wait until 6 weeks, there's a whole bunch of individuals that you may have lost because they're no longer here. And that weighs really heavy on my heart. And so, my huge thought about all of this is access to care. We know that the vast majority of individuals give birth in a hospital. Vast majority is like what, 98%, something like that. It's a huge amount. And why not take advantage? They're now in the system. Let's utilize resources while we have them. We have social work there. We have a whole medical care team who can get this person the things that they need before they go home. And then those rehab therapists can give them the tools, the education, the guidance of what to do for those next 6 weeks if they're unable to get in with another healthcare provider within those 6 weeks, whether it be a pelvic health therapist, whether it be someone who provides home services. But if they're not able to get in with anyone for those 6 weeks, at least we could make that difference and give them tools in their toolbox.
For the response, my knee-jerk response is we don't have resources. We don't have enough
Amen.
resources in hospitals. We don't have enough staff. There's 1.3 million C-sections alone that are performed in the United States. That's nearly double combined, right? Knee replacements and hip replacements. If you were to combine all of the joint replacements that we typically offer services to within the first 24 hours, we are hardly offering rehab services to those patient populations as a standard of care. So now you're asking us to double our workforce to just see patients after C-section or just see these patients after postpartum hemorrhage, which is second to mental health concerns, the leading cause of death within the first 6 weeks. We don't have the workforce. What is your response to that?
One, I would say that I'm not saying to just work with this population. I'm saying to change your lens, change your mindset. This is a population that needs us. This is a population that needs help, that our morbidity and mortality rate in the United States not only is the worst out of all developed nations by a long shot, and that is not something we want to be winning in, but it continues to get worse every year. We're not seeing a downtrend, which is what we would want. We're actually seeing it continue to go up. That is a problem. And for us as healthcare providers, maybe working in the hospital to prioritize someone who's had a gallbladder removal surgery, a very tiny, minimally invasive surgery, usually, compared to someone who's had a major open abdominal surgery, such as a cesarean section, and now has the added tasks of caring for themselves and their newborn, and we don't know their home situation because has anyone asked? Has anyone asked? So my response is not to, I'm not trying to burden other people, but I want others to recognize that is there a way that we could get to some if you can't get to all? And how do we prioritize what that list looks like?
Welcome, Kate Myers.
Hi.
Hello.
So I have a couple thoughts, and this is all just so lovely. And I'm fortunate enough that our hospital, we're providing acute care perinatal services now, which has been super. Sometimes one of the barriers that I have been finding, or when we go into a patient's room or we're talking with the nurse, they're bonding with their baby, they're doing skin to skin. And so sometimes convincing the mom, talking about why we need to do this falls on deaf ears in a way. And I'm trying to find the best language, I guess, to use with these patients. So not to scare them, but also emphasize the importance of it. And so I didn't know if either of you had thoughts on what is the best language to use with patients, especially when they are doing all of that bonding time. And how can you convince them to say, hey, let's go just do a little bit of walking. Let's try those stairs, XYZ.
If I can, Jenna, can I?
Please
And
go
then
ahead.
you
Yeah.
definitely.
Mhm.
But what I would say in those cases, so now I'm an acute care therapist now. And so oftentimes, sometimes if I come in and a patient is having lunch, that is just an introduction to here's the expectations for the eval that we definitely want to accomplish. I understand that if this is available to you or if it's not available to you, but if you do have maybe background of their social situation or home environment, or you're collecting that information up front within this like screen time, because when they're bonding, you're still doing part of the evaluation, which is the most valuable part, which is the subjective. So if you're just saying this is a service that we started providing to moms on the maternity unit, especially if you've delivered by cesarean delivery, we know a lot of moms don't necessarily have a hospital bed at home, and that might be a challenge. You're setting them up to say, I'm going to prioritize this. And when my baby goes down, please come back during X, Y, and Z. We do that for acute care patients all the time. We're constantly navigating all these other services, if you will. And sometimes we're making appointments. Sometimes we can't just come back. And maybe it's a time where they're like, this is so important. I actually really want to make sure that I'm paying attention. And so the first thing that I would do coming into that situation is just introduce yourself and say, this is a new service. This is a service that we're providing to moms. And we're really just gathering information to determine if this would be a benefit to you based on what you're going to be going home to. And when you frame it that way, and it's like more like optional and just kind of something that they can just listen to, go on, I would say just introducing it and really being specific, not just we're going to get up and walk, but we're going to make sure that you have the support you need and the resources you need when you go home. I had it down pat, the spiel. Jenna, can you share your spiel? Because I know that you had a really good one that I
No,
think I
this
stole a little bit of.
No, Rebecca, you did a great job. And I think that I would agree with everything you said. A lot of times I try to focus in, just as Rebecca said, what are the services that you're going to provide? And one thing that I've noticed that tend to perk their ears up or their eyes where they now look at you is if you start to talk about, I'm also here to help teach you ways to protect your incision during movement. I have literally had people, when I say that, they will like give the baby to the person that's in the room and say, help me now. Because if they don't want to open that back up, that is, you talk about walking, they'll be like, I've walked in the hallway. What's the big deal? Or I'm already getting up, moving around. Frame it about other areas that we can help them in. That think about someone, what are they really going to be concerned about? If they've never had surgery, many of these people haven't. They may not have ever had a surgery. They are not going to want to open that incision back up.
How do you do that without scaring them, though?
How do I do it?
Yeah, like you want to say, hey, we're going to go
Oh,
over this so that you don't open up your C-section or your
no,
perineal
no,
laceration. Like,
no, no. I say what I just said, just that, hi, my name is Jenna. I'm a physical therapist. How are you? Oh, congratulations. But then I go right into some of the things that I can offer, such as helping you protect your incision during mobility. I keep it as simple as that. And they know what that means. And I don't know. I hope that kind of answers your question. I agree with Rebecca. I like to offer it and think of things. These are, I can help protect your incision. We can simulate your bed at home. That's a lot of times I say that. And then they'll go, oh, because they'll realize, oh, I am sitting up and my bed is flat. Oh, I've actually only gotten up with the bed rails. That would be a useful thing for me to practice before I go home. And then if they say, sometimes, like I said, they'll just hand their baby off to the person that's in the room. And then other times they might say, can you come back in 30 minutes? They're feeding or whatever the case is. And I try to accommodate if I can, but don't be surprised if they want to see you right then and there and they
yeah.
give their
And
baby to someone else.
Jenna, can I just add one more thing to Kate? Sometimes a
Mhm.
lot of their concerns is around pain. And so if they've been sitting for a long time, especially if it's a perineal laceration or if it's a C-section, and I'm asking and I can sense they're just uncomfortable, My spidey senses are just on full throttle, right? Because their spidey senses are on. They're very sensitive to the energy in the room. And so if I can pick up that they are really uncomfortable, then I go away from the bed at home, the stairs at home, and say, has anyone told you about some things you could do to help with your pain outside of the medications that your nurse is giving you, the position in your bed, maybe lying flat, and then I'll go into examples that have helped other moms. Would you like me to show you that? And so a lot of times we talk about cesarean incision protection, but like being upright in bed, we've talked about this in other contexts, but for the therapist in the room, we wouldn't want to want someone after a knee surgery just rest their knee over a pillow for a prolonged period of time. But we know moms are upright and folding across their incision. And so when you see someone who's there and maybe no one has talked about them about their incision protection in that way or different positioning, that is also an entry point. I do focus sometimes interventions around reducing their pain or improving their comfort.
Helps.
I just, oh,
Helps. That helps. Thank you. Thank you.
Thanks so much for your question.
You're so welcome. Thank you. Awesome.
I
Excellent.
was just going to add something. I don't know if you can hear me.
Yes, yes. Is your video on, by the way? Would you like to come up?
My
Or-
video is not on. I have
No,
a
then
top.
speak away.
So
Introduce yourself, please.
my name is Jillian. I'm a physical therapist in Maryland. I've been in acute care for 6 years since I graduated PT school. And just in this last year, I transitioned to outpatient pelvic floor. Obviously, big jump, but I'm still working in acute care part-time as well. I gained interest in pelvic floor after having two children and my experiences with going through that. And I remember now back when I was in my early stages of acute care, getting a consult down to the mother and baby unit for a new mom who had what they thought was peroneal nerve palsy from being in the stirrups for so long, which is pretty rare, but happens. And I just remember they consulted me because her husband was having to hold her to walk her to and from the bathroom. She couldn't lift her foot up off the ground. And obviously this was prolonged. It wasn't something that the epidural just hadn't worn off. And I just remember at that point in time, I didn't have any pelvic floor experience, but I had experience in general teaching somebody how to functional mobility wise, modifications to make, ways to assist with making baby carrying tasks easier. And I spent a great deal of time with that patient in order to get her home safely. Obviously, her concerns were navigating the stairs, being able to hold the baby, being able to do all the tasks she needed to do with the baby, with her husband going back to work, all the things. And I think I had 2 1+ hour sessions with her that day so that she could go home safely. But now that I'm an outpatient, it's just so interesting to me that a lot of the patients I'm getting in, even as early as 6 weeks postpartum, which again is not early enough still, or do not have any education provided to them by the providers in the hospital. And so they're coming in and most of the things I'm talking to them about are new and fresh, even just as simple as massaging the C-section scar and like, why is that important and how that can help with not experiencing or hopefully not experiencing prolapse symptoms or bladder incontinence. So what interests me about this is that I really just wanted to learn how I can start to bridge that gap in the ways that I can. So this is all very interesting. So I appreciate all the insight.
You're so very welcome. Thank you, Jillian, for sharing that. That's super valuable. Yeah, Jenna, anything?
To add, or no, I
Yeah.
figured you might want to answer the question, but
Jillian, correct me if I'm wrong. You were like giving your experience and just thanking us for holding this kind of, yeah.
Yeah, I think a little bit. I also am just wondering, like, how does somebody like start this in a hospital setting that might not have something like this in place? What are the first steps to take in order to get this initiative rolling?
Can I answer it from your standpoint,
Yeah.
Jillian? It would be sharing a story and doing an in-service. That's it.
Yeah. Okay.
And the first team I would do that to is not the nurses, not the OBGYNs, because they're like, when can you start tomorrow? And I'm not kidding about that, is that when they actually hear it tied to a patient case, you don't have to have a ton of articles because there are none. but you can tie it to a patient case, a problem that you can solve. If you haven't talked to the rehab team, the acute care therapist who would really need to carry these services and make them sustainable, that would be a big mistake. So to be quite honest with you, is that we didn't quite do it the way that we recommend. But my recommendation would be to do an in-service to the rehab care team and even do it that with a patient population that's also similar. And it could just be one that's having issues with walking or difficult like discharge. It could be general enough so you make sure people show up, don't
Yeah,
necessarily
like
have it as a
peripheral nerve
maternity.
injury.
Nerve injury, peripheral nerve
Yeah.
injuries, or something like that, so you can get a good team. Jenna did a sneak move in her hospital where she actually did an in-service on abdominal surgery and hit
I
them with
did.
cesarean recovery and rehab interventions at the end and got a whole bunch of people interested. But that's really how you start a program in any population, oncology, maternity, stroke, best practices, whatever it is. You start with the rehab team and you get a team that's really going to carry this program to the end. Great question.
That makes sense. Thank
You're welcome. We have time more. Is it Eveline?
Hi, yes, it's
Hi.
Evelyn.
Evelyn, very
Hi,
nice to meet
Evelyn.
you. Thank you.
Yes, thanks. So I'm a physical therapist. We're at a trauma level 1 hospital. We are currently working on a task force to get us more in there in the maternity ward. But my question is, how do we make sure women in the emergency room don't get missed?
Yeah, I'll take this. Let me ask, do you have a presence in the emergency department
Yeah,
already? Okay. Do you mean postpartum or do you mean just peripartum in general?
both. Either one.
Okay. I think that may involve coordinating or speaking with the emergency department team. So, like the physicians and everyone that was involved in starting or initiating just having a physical therapy presence in the emergency department. And then providing an in-service about how here's this other population that would also benefit from our services. You're already a huge step ahead because you're already in the ED, and there are many hospitals that are still working on that. So you are ahead of the game, which is super exciting. I would add that though, because there's often, unless you have a separate OB ED, which some hospitals do, if they're a large birthing center, they'll have a separate ED just for the OB patients. But if yours is just a general ED, they won't have a dedicated OBGYN on the team. And so, go
No,
ahead.
I've been in the ED, but I don't remember having any patients who are pregnant, or if they have been, I don't think we have seen them in a different way that we are working towards, if that makes sense. So even
Yeah.
in the ED, there's only like maybe one primary PT, one primary OT, and maybe a secondary that flowed down the emergency department. And of course, it's overflowing.
Yeah.
So it's just one of those things that like where we could be helpful and see things that maybe aren't getting seen because it is the emergency department, and we're able to give more to these patients than anybody else can.
Absolutely. I would say, again, doing an in-service might be really useful about low back pain during pregnancy and how there's even something you could do to help with that. Or in the postpartum, also coming in, whether it's pelvic girdle pain or a number of different things. I will say if they're coming in because of a postpartum hemorrhage or for hypertensive emergency, that's likely not something you're going to be able to help with. That's more of a medical emergency that's going to lead to them being admitted, and then they would need our help afterwards.
Evelyn, can I add to this? And I'm going to use Jenna as
Please.
an example. Evelyn, are you still with us?
Yes, I'm here.
So this may actually help because this isn't a concrete example. When we moved on from the rehab in service, and Jenna can correct my understanding of this, but I was on the call when she accepted the invitation to speak to the OBGYNs. at the second hospital where she started services for the maternity population. And she had this 15-minute presentation all planned out. Like she was going to be given 15 minutes. That did not happen. What happened was that the OBGYNs were having a fit because at the time, around the time of COVID and then still into 2021, the hospital had closed the OBED. And so what was happening is that the ED, the regular general emergency department, was overflowing with obstetrics patients also being in the mix, and they didn't have a dedicated OBGYN, and the OBGYNs not also operated on call, and they weren't necessarily consulted in time. And so they were just really focused on that. So here we are panicking because we had developed this PowerPoint, this presentation to talk about our services on the maternity unit, but that's what the team was focused on, was their
They
ED
were
issue.
stressed about it.
And they were stressed about that. So Jenna decided to chuck her whole presentation. She never opened it at all. And she being the EDPT for one of our level 1 trauma center, she focused on how could she screen as a physical therapy those patients who were not the high risk postpartum hemorrhage, medical attention is needed right now, but those who were coming in for back pain or pubic symphysis dysfunction that felt so severe, musculoskeletal, all of that could benefit from PT services rather than emergency services or being admitted to the hospital. And that's where she's going for with the in-service. And I'm the one to just call her out because I need concrete examples when you have them, Jenna.
Sorry. And something else in that exact example actually is that not only was I talking about what I can help with, at least what I can help with in those situations, but I also spoke to how we could even try to prevent the ED visits in the first place, by at least in the postpartum population, by having rehab be a standard of care after delivery. We could even prevent them from having to come back to the ED. And they loved that because they were so stressed. They were stressed about the crazy numbers that they were getting. And it could be, they were getting things for infection. They were getting wound dehiscence. They were getting, of course, the hypertensive issues, preeclampsia. And these were all things that, of course, I was trying to argue in a way that we could really prevent some of these things from happening. And Evelyn, does your program at your hospital, is it already up and coming in terms of postpartum services? Are you already there? It's happening. It's auto.
Trickling in. I have some other colleagues on the call as well. I think we're
great.
Slowly getting ourselves. I know we've all are taking courses very slowly and really we've implemented a little bit in, but we're working on this task force to really make our presence known in there.
Oh, that's awesome. That is great. So that could even, if you are going to have this in service with ED providers, you could even slip in, you could prevent people from coming to the ED too, to help with that program development, the postpartum perinatal development.
Awesome question, Evelyn. Thank you so much. There was a guest that we usually have had, a past guest, that just left something for us in the chat. I would love for her to actually read it out loud if she would be willing. If I don't hear from her, I'll definitely read what she wrote. But Dr. Catherine Sylvester, if you are willing to just unmic, you don't have to put your video on, but if you want to, please, will you just leave us with some final thoughts of when you believe OT and PT should be offered in the hospital after birth, to wrap up our talk for this evening.
Hey, everybody. This has been so incredible. Oh my gosh, I've just been sitting, taking notes, taking it all in. It's so nice to see people so invested in moms and being able to do it safely, starting with the students. And so I would say that I love that you said within the first 24 to 48 hours, because we're seeing moms being discharged same day sometimes. And if they've had a quick delivery, everybody's, oh my gosh, that was so good. It was so fast. And not realizing that could be the very thing that makes them go back. And so I have seen someone 2 days post with fluid overload, and the cardiologist was like, oh my God, you wouldn't have survived. But it's watching those vitals. It's making sure that we're advocating for moms and that we don't. So yeah, I know that you all talked about not scaring people, and I hear that. But sometimes a scared person will implement what you're saying and will listen. And it's not that we're trying to make it a scary situation. It's that we're educating them about the possibilities so that they don't return. Because the scariest thing for a new mom is to be separated from her child. And so if we can explain to her, that's why we're doing this. We've seen it happen the wrong way, and we want to make sure it happens the right way with you. It gives them a little bit more buy-in. But I have never, to be honest with you, I've never talked to a mom before delivery who and told her, you need to ask for physical and occupational therapy when you're in the hospital. You need to make sure that they're taking your vital signs with activity. There has been zero pushback, none. And so it may be that it depends on how the education, when the education is given, because just like people are told, hey, have a lactation consultant come to your room before you leave the hospital. It could be that latching goes very well there, but when you go home, it could go downhill. People are like, hey, I need a lactation consultant. Don't send me home without a lactation consultant. That is the day that I'm looking forward to with physical and occupational therapy, that people are demanding it and not leaving the hospital without it because they know that their life or their livelihood literally depends on it. We have got to get past what is the impact on them physically and start thinking, what is the impact on them physiologically? Because patients don't know to do that, but we do. So thank you for all that you do. I just say that for anybody on here who is nervous about starting, take this course. And honestly, I know that you didn't say this, either of you, lovely Dr. C. Graves, but when a hospital department wants to implement this as a rehab department, the next step would be for them to be trained through ERAD, right? Doesn't that just make sense? Because if it's a population that they haven't been to yet, it is very common for therapists to feel nervous. And that's okay. And I know that we're trying to say that, look, these are skills that they already know. These are things that they should know how to do. But at the end of the day, it's because it's not commonplace. People may need a little bit of extra support. So I would say that if I were starting it anywhere on a grand scale, I would encourage that department to have everyone go through the ERAD course so that they can feel comfortable going out and treating these ladies effectively.
Thank you so much, Dr. Sylvester. And then first, we
Yes,
also
ma'am.
have to just do a commercial with Operation Mist, right? So that moms are aware of what they should be asking for in the hospital, right? Just like you said, if you are actually educating a mom on the services that a lactation consultant can provide them, they're more likely to ask for said services, and those services are able to be provided. They magically appear when a mom asks for them. And so if they were also educated on asking for an OT or PT evaluation, those commercials then through Operation Mist, and we didn't even talk about your wonderful organization that is responsible for monitoring moms remotely during pregnancy up until the first year postpartum, is something that is unheard of for me, is something that I am completely enamored with. The idea of having someone not just remotely monitor through smart devices, but contact that mom and just ask, something changed? Did you eat something different? Or how did you sleep last night? A real human being asking a mom during pregnancy or immediately postpartum, has anything changed? And Dr. Sylvester, I don't know if you were with us when we shared those stories at the beginning, but could you imagine a mom checking in with her provider, that one of the 4 health contacts that the World Health Organization wants us to offer within the first 6 weeks? Can you imagine a mom checking in with a mother who delivered by twins before her 9 days, or the mom who had a blood clot before her 2 weeks, or the mom before her 4 days postpartum? Could you imagine someone doing a wellness visit when she was still alive? And you can see things on your remote monitoring devices and technology that we're now just being exposed to as rehab professionals. You are seeing things as the curator, as the CEO of Operation Mist, that we haven't even been exposed to as rehab students and professionals. So please, commercials first to the mom. And then I think the training will make sense to everyone involved. Thank you so much, Dr. Sylvester.
Thank you.
Thank you, everyone,
Thanks.
so much for being a part of this evening with us. And we wish you well. And please do get in touch with us if this was inspiring to you. This recording will be available to everyone who wasn't able to join us live, but then also any resources that you wish to have to really advocate for services in your hospital system. We really try hard to make all of that accessible. So thank you so much for attending this topic with us tonight. Have a wonderful evening.